Hi everyone, and welcome to this webinar presented by the Multicultural Centre for Women's Health. My name is Santila Chingayipe. I'm a journalist and filmmaker, and I'll be moderating today's event. I'd like to respectfully acknowledge that this conversation is taking place on unceded sovereign land. I'm joining you from the land of the Kulin Nation. We pay our respect to their elders, past, present, and emerging, and to the elders of all communities that this conversation reaches. So a quick reminder that this webinar is being recorded and you'll be able to ask questions towards the end of the event via the chat box function. So today is an important day because there are two reports that are being launched by MWCH, being Sexual and Reproductive Health Data Report 2021 and the Act Now to Advance Health Equity for Migrant and Refugee Women's Sexual and Reproductive Health. We know that migrant and refugee women regularly experience inequitable access to services and poorer sexual and reproductive health outcomes than non-Indigenous Australian-born women in the Australian health systems. And it's through data and research like this report that we can work towards finding solutions that narrow this gap of disadvantage. So we'll be hearing from a wide range of speakers this afternoon. But first and foremost, I'd like to introduce Dr. Tamara Kwarteng, who is the board chair of MWCH.
Thank you, Santila, for the warm welcome. Good afternoon, everyone. I'm Tamara Kwarteng. I'm the chair of the Board of Management of Multicultural Centre for Women's Health. I also would like to acknowledge that I'm speaking to you from the lands of the Wurundjeri people of the Kulin Nation. And I'd like to pay my respects to elders past and present, and to recognize that the sovereignty of Aboriginal people has never been ceded. I would also like to acknowledge our special guest today, the Honorable Greg Hunt, Minister for Health and Aged Care, who will be launching our reports via specially prepared video message. Our wonderful facilitator, Santila Chingayipe, and our esteemed panelists, Devaki Ashna, Bonnie Corbin, Andrea Criado, and Dr. Nisha Kot. On behalf of the MCWH board and staff, I'd like to thank you for joining us today for the launch of our Sexual and Reproductive Health Data Report and Act Now paper. We are excited to share these two documents with you. These new resources have been developed for the use of researchers, clinicians, community practitioners, policymakers, and advocates. They bring together the available Australian research on migrant and refugee women's sexual and reproductive health so that we can draw on the current evidence base to advance health equity across Australia. The resources that we are launching today show that migrant and refugee women have lower levels of access to sexual and reproductive health services, and they have poorer health outcomes in a range of areas. The Act Now paper provides recommendations for improvement, and we will explore some of these issues further in our panel discussions shortly. We are here to talk about advancing health equity. Now, advancing health equity has been MCWH's mission for over 40 years. Our national program, Multicultural Women's Health Australia, and we have several network members joining us today. Thank you for attending. Includes sharing research, important research on migrant women's sexual and reproductive health, delivering training to service providers, disseminating multilingual information, and providing advice to government on policy and legislative issues. We work with multicultural communities and researchers, with women's services and health services to promote health and gender equity. We work towards changing systems, policies, and cultures, and we strive for equality, justice, and well-being. MCWH welcomed the announcement in the last budget that the Australian government invested $535 million into women's health. We are following up the budget commitment, and we look forward to working with the government to ensure that it can be directed to improve migrant and refugee women's health and well-being in the various ways outlined in the Sexual and Reproductive Health Data Report and Act Now paper. We hope that the resources will help guide your work, and we look forward to hearing your thoughts and feedback. By bringing our efforts together, we will make a difference to the health and well-being of migrant and refugee women in Australia. Thank you again for attending, and best wishes. And at this time, in the times that we are in, I'd like to also say, stay safe wherever you are. Thank you.
Thank you, Dr. Kwarteng. I'd now like to introduce to the webinar the Honourable Greg Hunt, the Minister for Health and Ageing, who will officially launch the report and paper.
Well, welcome everybody to the Multicultural Centre for Women's Health launch of the Sexual and Reproductive Health Data Report. And the report's findings are very clear. And I want to thank everybody involved for it, in particular Dr. Adele Modolo, but all of those researchers, clinicians, community workers, and patients who've had input. And those findings are that non-Australian born women have lower rates of accessing earlier treatment than Australian born women. We know that within our migrant community, that can lead to mental health outcomes. That can lead to delayed treatment. And so these are really important findings. And so the Centre's work and this report mean that we have a task before us. And so the challenge is to ensure not only is there better data, exactly as the report sets out, and I support that in terms of the disaggregated data, the publicity and publication of it, but the education which follows. And so as a consequence, as a country, as a nation, as a government, what we are doing is responding, as we have just done in the budget, with a $535 million package for women's health. In particular, that includes a strong, clear focus on education, and that's not just generalised education, but for Australians of non-English speaking background, for women who might suffer from endometriosis, might suffer issues of mental health, might not seek the sexual and reproductive health advice because of cultural barriers or the fear of response within their own circumstances, and also for women who may not seek early diagnosis and therefore early treatment for breast and cervical cancer, amongst other conditions. And so this package of $535 million is about women's health in general, but in particular, it's about supporting the health of women from non-English speaking backgrounds. It's about celebrating multicultural Australia and multicultural Australian women, where whether it's culture or language or origin, there may be inadvertent structural barriers to seeking that early treatment that can save your life or improve your life. So ultimately, I welcome the Sexual and Reproductive Health Data Report, and I want to thank the Multicultural Centre for Women's Health and acknowledge the work of all of you in putting this report together. It will save lives and it will protect lives.
Thank you to Minister Hunt for that message. So the report is officially launched. I feel like confetti should be falling from the sky. So we're actually going to have a conversation now about some of the data in the report. And I'd like to introduce some of the panelists, but what I might do before that is ask any of the panelists that are not appearing on camera to, if you can, just turn off your video and mute your microphone. Just so that way we can just have a very smooth facilitation of the process. And also just a reminder to the audience that there will be an opportunity for you to direct questions to any of the panelists towards the end via the chat box function in Zoom. So let me begin by introducing our panelists this afternoon. First and foremost is Dr. Nisha Kott, who's a former clinical director of obstetrics at Western Health Service and Victorian counsellor at the Royal Australian New Zealand College of Obstetrics and Gynecologists. Bonnie Corbin, who's the chair of the Australian Women's Health Network and head of policy at Marie Stopes, Australia. Andrea Criado, who's the Chief Executive at Isha Multicultural Women's Health Services, Western Australia, and Debaki Ashner, who's a bicultural community health worker, Australian Red Cross in Tasmania. Welcome to all of you. I might begin with you first, Dr. Kott, and I want to know, what are the most pressing sexual and reproductive health issues for migrant refugee women in the area that you work in?
Thank you very much, Santilla, and I'd like to begin by acknowledging the traditional owners of the land on which I am, which is also the same as Dr. Tamara Kwarteng. I would also like to acknowledge that Indigenous women have been birthing on this land for many, many, many years. What are the things that are specific to sexual reproductive health care in the field of childbirth? Now, the thing is that childbirth doesn't occur in isolation, isn't it? It occurs in the bigger context of actually having good health care for all women. What I see every day is the fact that is also highlighted in the report that migrant and refugee women have higher likelihood of developing complications in their pregnancy, things like preeclampsia, things like diabetes. They're more likely to have premature preterm births. They're more likely to have complications during the birth itself. They're more likely to have things like cesarean sections, things like needing to have a forceps or a vacuum birth, more likely to bleed after they've had a baby, more likely to have significant tearing after birth. Now, that is all sort of the physical side of things, but it's also important to remember that these are women who don't always access healthcare at the same time in pregnancy as Caucasian women Caucasian women and non-migrant women. They also may have language and other barriers. So how I look at it is there's the sort of group of factors that affect women of migrant and refugee origin in general. So things like language, things like access to transport, access to healthcare literacy, ability to understand what is being said to them in a language that is foreign to them, access to literature that they can read and understand, which is in a language that they can read and understand. There's also the environmental factors, and migration, we know, comes with a whole host of environmental factors. Trauma that you may have experienced in the process of migration, in the process of becoming a refugee, trauma that you continue to experience because you don't have the same family and social networks that you would have had because you are in a foreign nation, in a nation where you don't have any roots or connections. There's also the fact that you have certain genetic things that are specific to a particular genetic group. And, the sort of common thing is things like thalassemia. Yes, we know that certain genetic conditions are more likely to happen in certain groups. But the other side of it is the fact that when we look at the health of migrant women, even when we compare the outcomes for first, second, third generation migrant women, we find that there's still a gap. So when you think about third generation migrant women, these are women who have probably grown up in Australia, they know the language well, they can advocate for themselves, but those differences in outcomes don't get back to zero. They still exist. And so I think there is a very important thing that we should acknowledge, that we can't always put these differences in outcomes down to not being able to access healthcare, or not being able to advocate for yourself, or not being able to understand the language. There is something that I think healthcare professionals need to recognize about why there is a difference even when women can speak the language and can advocate for themselves. Is it because we view migrant and refugee women, or women who are of a certain ethnicity, differently? And do we treat them differently? This is a really important question to ask ourselves. And that is not because, we consciously are doing it. It's because we all have our own unconscious biases that we may not recognize unless we actually take the effort to find out what that bias is and how it's affecting our interaction with women. The other thing I also always say is that women may not understand the language you speak, but all women understand body language. And so as a professional, wherever we might be, when we have that body language, when we're seeing a migrant or refugee woman, that clearly says to them that, oh gosh, not this difficult conversation, the woman understands. You may not say it in words. Your interpreter will not need to interpret body language that is clear for a woman to see. So again, that is not something that we consciously do. I'm pretty sure that all of us consciously want to give the best healthcare, but it's an unconscious thing that, it's at the back of our mind, and it sometimes comes across in body language. And that is also really important for all of us to recognize. So those are the sorts of things that I see happening around me being a healthcare professional. And I think a lot of it should come back to us. Yes, education of women is important, but putting the onus constantly on women to have to advocate for themselves shouldn't be how it should be. I think we should learn to recognize for ourselves as well how things change for us.
Wonderful. Thank you, Dr. Kott. Bonnie Corbin, if I can come to you, I wonder, what are some of the most pressing issues in this area that you see in your line of work?
Thank you. I will start also by acknowledging that I am joining this webinar from unceded Wurundjeri country, and I pay my respects to elders past and present. The most pressing thing that I see in this space is how often migrant and refugee women's health is spoken about in the media and public affairs, but how little that translates into investment and action. So the Minister just before spoke about the federal budget, and the budget promised $535 million to women's health. But if you do the numbers, that equates to less than $15 per woman per year. In addition to that, none of that money has yet been allocated to migrant and refugee women's health through targeted or specific funding streams. When it comes to sexual and reproductive health, in particular in abortion care, at the moment we're fighting for women to access any service provider. In an ideal world, people would not only be able to access safe and quality healthcare, but they would have autonomy to choose from a number of health service providers. Ideally, migrant and refugee women, including women on temporary visas, would choose from a list of mainstream, specialist and community-controlled health service providers, depending on their personal needs, interpersonal relationships and community context. We know that community-led and community-controlled service providers are more likely to centre intersectional needs of women. For example, migrant women with disabilities, LGBTIQ+ migrants and women on temporary visas. We are the health system, and we need to act now to overcome the barriers demonstrated by this report. We need to build health pathways that enable a variety of personalised and community-centred care. If this government is serious about migrant and refugee women's health equity, they will invest in community-controlled migrant and refugee women's health services. Thanks.
Thank you. Thank you. If I can come now to Andrea Criado, I guess a similar question as well. Have you seen the report's findings reflected in the work that you do?
Yes, definitely. So here at Ishar, we are a community-based women's health service, and we see over 2,000 women from migrant and refugee backgrounds each year. And we find, even now, 20 years later, working in the sector, that the issues highlighted in the report are prevalent. We see it every day. Women find it difficult to access services. They are higher risk of getting, STIs, they are at higher risk of multiple pregnancies that they don't really want, necessarily want to have, cultural barriers, religious reasons, lack of understanding of the health system, access issues, and very low health literacy. All of these factors combined together get presented in practically all the clients that walk into our service. And yes, there is a need to have services that go out to the women, because accessing them is for a number of factors, like Dr. Kott also highlighted. Just transportation is difficult. So yes, I would say definitely all these issues are seen by the women in Western Australia as well.
And lastly but not least, Debaki Ashna, do you see these issues also reflected in the area of work that you do? Debaki?
Hello, can you hear me?
Yeah.
Sorry, I was mute. I would like to start with I acknowledge with deep respect the tradition owners of this Aboriginal land and the Palawa people. Yes, I see all the challenges in my community as well. Where I work for a Bhutanese and Nepalese community, and especially the Bhutanese community who came here as a refugee. They have a very low health literacy, and it's very harder for them to access the health services. Due to low. Hello?
Yes.
Oh, sorry, my voice is going off.
We can hear you.
Oh, shit, thanks. Yes, due to low health literacy, people are not getting a good quality of health services because they got access to some services that is available for them. They don't even have any idea about what services are available for them and what type of services they can get.
Mm-hmm. So did you see anything in the report's findings that is also reflected in the work that you're doing?
Yes.
Great. So I might go back to Dr. Nisha Kott, if I may. And you talked about the sorts of issues that I guess women from migrant refugee backgrounds are more predisposed to. And I wonder, in terms of the data and research within this report, how can we use the evidence to build better health systems?
So Santila, I will start with one of the statistics in that report, and the report has a statistics on stillbirth rates. And it says that in 2018, the stillbirth rates for Australia in general were 6.7. But if the mothers were born outside of Australia, that stillbirth rate was 7.3 per 1,000 births. And in 2013-14, about 34% of stillbirths occurred in Australia, in women who were born outside of Australia, which tells a story. It tells a long story of what the issues might be that lead to that sort of, when we talk about stillbirth, that stillbirth is usually just the tip of the iceberg. Underneath that, there are a whole lot of other outcomes which are poor outcomes, but we see the stillbirth because it's one of those things that is obviously a tragedy in any woman's life. Now, we recently, as a community, launched program to reduce stillbirth rates across Australia. It's called the Safer Baby Bundle, and anybody can look it up, and it's got a few components to it that looks at how we can reduce stillbirths by simple things like making sure we give women education about smoking, we make sure that we regularly monitor babies' growth, we make sure that we act whenever we find a problem within the movements or growth, and we make sure that we give women advice on healthy living and sleeping on the right side, on the left side, and things like that, which are all good things to reduce stillbirth rates. But it doesn't have a targeted focus for women who are born outside of Australia. And we see that repeatedly in various different policies. We look at various policies across the spectrum of healthcare and women's healthcare, and we see that there's always good advice, but often the advice doesn't actually speak to a group of women who are more likely to have that outcome. Similarly, we have the cervical screening guidelines, for example. We've got very good information available for women about cervical screening, but we know that migrant and refugee women are the lowest proportion of women who will access cervical screening programs. And so what we need is that targeted information for these women. The other side of the story is that that targeted information is best accepted when it comes from within your own community and your own group of people. A lot of people saying the same thing over and over again may not have the influence that one person from who is a respected leader within your community, whom you would trust, saying it would have. And so that, I think, is the nuance here that we sometimes miss. I think we often miss it. And that is what will actually help make a difference. And so, like we said, the community-led organizations are the ones that will make a difference. And I think that's where we need to focus our attention. We'll get more bang for buck, as it were, from those sorts of initiatives.
Right. So, so you're essentially saying that, you know, we clearly know about where all the for lack of a better term, all the gaps in the system are, and report after report keeps highlighting this. But the discrepancy, I guess, is happening in the lack of funding. Is it the target? Is it funding to sort of be able to sort of ensure that, you know, as you say, these programs can be more targeted?
Absolutely. I think there is a place for funding and targeting of information. And it again comes back to who's sitting around the table making those decisions. And, you know, I guess, talking about what is within your community and what you see is something that needs to be discussed at the table. It can't be people who don't have a lived experience of what that community actually goes through. And so the more people we have on all sorts of policy making tables, whether they be at the government policy making table, whether they be at a local hospital-based policy making table, it's very important to have the voices of migrant and refugee women there so that we can advocate for our own communities. And I speak of that as, you know, a migrant woman myself and a migrant healthcare provider myself, so I can see both sides of the coin. And I think that is really important, to have equal representation.
Great. I'll come back to you a little bit later on, Dr. Kott, but appreciate your insights there. Bonnie Corbin, if I can come back to you, just picking up on what Dr. Kott talked about there, I guess from your perspective, how do you think we can build better health systems that support women from migrant and refugee backgrounds?
Thank you. From my perspective as a health professional, it's about our duty of care. And a lot of this language that we've heard earlier on about putting the onus back on the patients, I guess, is not the place to start, and particularly requiring, like, putting the onus on educating patients, I guess. I'd flip it the other way around and say we need to bring the health system to the patients. And I guess I'd start with looking at discrimination in clinical settings, and in particular discrimination on the basis of race, citizenship, visa subclass, gender, languages spoken, or any other intersectional aspect is healthcare discrimination. And it compromises the right to health, which we're a signatory to. So we have international obligations to provide safe and quality healthcare without barriers and without borders. Now, the key strategy that we work to in this space is the Australian Government National Women's Health Strategy, and that was published 2 years ago now. And sexual and reproductive health is the very first priority area. And that section recognises that migrant and refugee women experience significant sexual and reproductive health barriers. It promises equitable access to sexual and reproductive health care, including abortion care throughout Australia. We're now 20% of the way into the Women's Health Strategy, and we're in the middle of a pandemic. And women's health equity and gender equity more broadly is at risk of regressing rather than progressing. So I think we can use the evidence in this data report to map health equity for migrant and refugee women and to monitor progress of the National Women's Health Strategy. Because if that strategy is to progress, we will need much greater investment in migrant and refugee women's health, and particularly healthcare provision, and particularly for women on temporary visas.
Thank you for that. If I can come to you with the same question, Andrea Criado, how do you think we can build better health systems off the back of some of the research in this report?
So some of the key issues as highlighted by other speakers and in the report is as access. So a better health system, we already have certain infrastructure processes in place, like we have access, the GPs have access to interpreters, but a large number of them will not use an interpreter for a woman who requires one. So it's about educating and possibly incentivizing a number of doctors in the community to use interpreters, just so that it becomes easier for women to go and see doctors around their sexual health issues. There are not that many community-based women's healthcare services with female doctors where the women will feel more comfortable to go and access services. So which is why I'm saying that if we incentivize this and pay doctors a little bit more to use an interpreter, that might reduce some of these barriers. The other barrier, of course, is transport and the number of children that a lot of women from COL backgrounds have, which prevents them from attending an appointment, particularly preventative health appointments. So we often find that if women are being called in for a pap smear, they will not come because it's preventative health. They think, I'm not sick. I'm not going to take the effort to carry 3 and 4 of my children across public transport to get to the center. It's just too difficult, and it's not necessary. They will only come if they are already really ill or sick or require some serious care. So I think taking services, particularly preventative health services, out into the community would help through mobile vans, even if it's in the metropolitan area. That would definitely help us reach out to more women and to do some of the essential preventative screening that is required in order to get better longer-term health outcomes.
Great. And just staying there with you, Andrea, there's a question that's just following up on what you talked about with the interpreters. And Caroline's asking, do you think working with interpreters is acknowledged as a skill that requires training, protocols, resourcing?
Absolutely, yes. Working with interpreters requires, you need, correctly trained interpreters who are trained to talk about medical terms and terminology, who are trained to maintain confidentiality. So yes, we do require the resources for that, and also giving clients the option of whether they would like telephone interpreters or on-site if it's a community-based health service. But if it's a JP, just them being able to access properly trained interpreters is necessary.
Great, thank you. And Debaki Ashna, if I can come to you, how do you think we can use this evidence to build better health systems?
Well, yeah, most of the topics are already covered by other speakers, doctors. Well, I would like to tell something from my community. What's happening lately is other doctors and the specialists are not providing the interpreting services. So people can't access to the GP or any of the sexual health organizations or clinic because they are not providing any of interpreting services. It's just really hard, which is a big issue now in Tasmania, especially for a Bhutanese community. They are living with so many of health problems, but they can't go to the places to get a support because of language barrier, and they don't get any support from a clinic as well. Yeah, and services need to be reached out to community more, community. So there are heaps of services available, but community does not know about it because of language barrier, because of they are in a foreign country, so they don't have any idea that there are organizations and health services, but they are very hidden. So community, the services needs to reach out to community. And yes, as the doctor said, more female doctor required. Like, I think we really need to have more female doctor, because ladies are not really open to talk about this topic, especially from my community where I work. They are not open to talk on this topic. Sexual health and the reproductive health is not really open topic in my community. We really don't talk to anyone. Even myself, I don't talk to my mom, or I don't talk to my parents. So it's really a very same topic in my community. So we can't talk to anyone. We need to have more female doctor and more flexibility with appointment. If the people are living with some sort of illness, they can't get an appointment immediately. They have to wait for another 3 to 4 weeks, which is a long while for them. That's why also they don't want to go to the hospital for any of sexual problem. I think we need to put some fund on interpreting services to get interpreting services quickly and easily, and get more doctors, and especially having like a worker from a multicultural background, because like I would tell you my case study. Before I was working at the Red Cross. Red Cross is not non-organizations from a community. They didn't know anything about the Red Cross and the health worker from there. But since I started Red Cross, I am facilitating information session about the health, information session about the lunchbox and things like that. And I do run a session on every Wednesday for a 12 to 25 years old girl, a young lady, for a sexual health. Since then, they know more about the Red Cross and other health organizations.
Thanks for that, Debaki. It seems to be a common theme around the importance of culturally appropriate care in communities. I think I might bring back Dr. Kwarteng, because there's a question here that's specifically asking about the report itself. And the question is, are there statistics in the report that suggest that women from culturally and linguistically diverse backgrounds are less likely to seek medical help for sexually reproductive health issues? Dr. Kwarteng, are you there? Don't know what's happening, Dr. Kwarteng, but I might get Dr. Nishikot to answer that question if you're across the full report. You know, so I don't know if you heard me when I said that, but I'll repeat it again just for your benefit. One of the panelists, Joy, asks, are there statistics in the report that suggests that women from culturally and linguistically diverse backgrounds are less likely to seek medical help for sexually reproductive health issues, and what some of those barriers are?
Yes, absolutely. And, you know, the barriers, like I've said, part of it is the health literacy and knowledge around health. It's important to remember that for many women, the countries where they come from, preventative healthcare does not exist. Healthcare only exists as a treatment. When something's wrong with you, you go to the hospital, you get treated. So the whole concept of preventing any condition is something that could be quite alien to women who have come from different healthcare systems. And so placing importance, the Australian kind of healthcare system and a lot of the Western healthcare system now is rightfully placing a lot of importance on prevention. And that is something that is difficult to get across when you have not had that as part of your normal healthcare. And so that is one part of it, you know, not having the ability to understand what prevention is, or the ability to read what information is available and to access those services. Like Debaki said, so many women are not aware that there is help available out there, that there is a service available out there. And so how do we make women aware that the service exists, and how do they access the service? The report shows that perinatal mental health and generally mental health issues are higher among migrant women. It also shows that family violence is something that migrant women are more likely to experience. Now, one of the things I previously spoke about the fact that we need targeted information, but sometimes there is value to having non-targeted or universal information. So one of the things that has happened in recent years is that questioning of a pregnant woman to ask her if she is safe at home or if there is anything that constitutes family violence. And that's not just physical violence, but also coercion, things like, being made to feel little or being made to feel unimportant, made to feel scared. Those questions have become something that is now mandatory to be asked to every pregnant woman. And I think that is the sort of other side of the equation, that sometimes you don't need targeting, you just need to ask the question to everyone, make it something that you would normally ask everyone. That gives women the space to be able to bring it up and to be able to talk about it. And it gives the professional looking after the woman the space to be able to discuss that actually violence isn't just physical violence, there are other forms. And if you are experiencing those other forms, there is help available. And so that, I think, is a very important thing also to talk about, that it's not always targeted. Sometimes not targeting is also helpful.
Great, thank you for that. Bonnie Corbin, if I can come to you, I guess in terms of practical things that people working within the sector and advocates can sort of do to sort of advance health equity for women from migrant refugee backgrounds. I mean, do you have any tips, advice on what some of those things can be?
Thank you. I feel like I'm in the background going, yes, yes, yes to everything that everyone's saying. So like really hearing the conversations today are important, really reading these two reports are critical. For me, when I think about health equity, I think about knowing when we need to share power and knowing when we need to give it up, and how we can apply that to every aspect of our lives. So as health professionals and health consumers, as carers within our own communities, we are the health system, and the health system's evolving. When I think to migrant and refugee services specifically, I think about how we can support migrant and refugee women's health services in our own regions. There are lots throughout Australia in different spaces and places, and every one of those services are under-resourced and undervalued. Some are funded, but they're funded on short-term funding cycles, and others are throughout communities in different forms. So I think particularly thinking to the spaces that we live in ourselves and how we can support each other and services in our own communities is critical.
Thank you. Andrea Criado, if I can come to you with the same question, but before I direct that question to you, there's a question that's also come in through the chat box that I also want to direct to you. And this one, the questioner asks, as a young woman of African descent, I believe that open communication is essential between parents and children, and I find that topics on sex and sexual health are almost taboo within the community. How do we get around that, especially for young women?
Do you want me to respond to that part about the conversations with young people?
Yeah, yes. Within the community and with
yes. So we picked this up as well, that having conversations not just between parents and young people, but we also have a number of women who would come to our services and their partners, the husband, or sometimes even the fathers, insist on being the interpreter. So, you have to institute some really strict, and we tell them we have a strict policy that we do not use family members at all as interpreters, so that the woman gets the necessary level of privacy in order to have the conversation that she needs to have with the healthcare provider, be that the nurse or the doctor. We do the same thing when young women come to us, because sometimes the mothers or aunties who are accompanying them insist that they are in the consult, and we explain to people that we have professional interpreters. There's a high level of confidentiality maintained. But another program that we've started out is we go out into the schools and have a series of talks on sexual health, how to say no, consent, a whole lot of issues that talks addressing a whole lot of issues that have been coming up all around sexual health and violence. The uptake of that has been very good, extremely good. And as a result of which, we have a number of young women now coming into the center to seek information and services for themselves. So I think a good strategy would be to be able to go into the schools, because they are getting information in a safe environment, away from elders of the community, but also professional information, and then a follow-up to come to a certain place to have a private conversation if they want to after school. So that has proved to be really successful so far here, and it could be something that could possibly used in other areas as well, across, in other states as well.
And do you also have perhaps some practical tips or advice in terms of actionable things that people within the sector can do to advance the health of women from migrant refugee backgrounds?
Yes, health promotion programs, going into the community and talking to the women, not necessarily having to just give out a whole lot of information. And I saw in the chat some people talked about telehealth. It doesn't actually really work with all migrant and refugee families because they don't have the infrastructure necessary. But we find this going into the community and having talks with the women helps tremendously. Leaving them with a little bit of just a bit of a card or a fridge magnet with an organization's name and number on it is useful enough, because they come back. We find when we do our sexual and domestic violence talks, we have from every talk, at least 10 to 15% will come back to access services. Just being very strict on policy when people say, we want to use family members, just saying, no, we've got strict policy, we are going to use interpreters. That just gives an opportunity. And another, when the cervical screening changed from 2 years to 5 years, what we did was we just sent out a wellness check reminder or a phone call, because letters don't always work. It's a highly transient population. They move a number of homes. We phone them up and say, would you like to come in and have a chat with the doctor around, just to see how you are going? And so it's a wellness check. And there's a huge uptake on that. So that was a very simple thing we could do, which allows the women to come in. It's just a good segue and an opportunity to discuss health issues with them. It has led to, often it leads to discovering that the women are genuinely in need of healthcare, but they've just not had the opportunity to come in, or didn't know that they could come in and talk to a doctor about something that was just bothering them. Like Dr. Kaur said, in most countries, people only see a doctor if they're really sick. They don't come to prevent any illness from occurring.
Santila, could I please add something?
Absolutely.
Just because I've seen quite a few questions about the discussions around sexual and reproductive health and things like contraception and, those sorts of things, and the fact that it's actually a taboo to talk about it. So one of the simplest things that I have been involved in, and it's, in pre-COVID times, it was in person, we just meet for chai. You get together a group of mothers meeting for chai, and nowadays it's on Zoom like everything else, but it's a chai conversation about, let's talk about our sexuality. We are whatever, 30s, 40s, whatever our age might be. So what information did we get when we were young girls about menstruation, about sex, about attraction to the opposite sex or to the same sex, how to be safe from pregnancy, how to be safe from sexually transmitted infections, what is consent. And the conversation is so interesting because as mothers, none of us have had any formal education about any of this. It was all discovery. It was all friends whispering to each other. And so then you can go on to having a conversation. Well, what would have made a difference if you had known this when you were 12, 13, 14, whatever your age? And now that you have a child who is 12 or 13 or whatever their age is, would you feel that your child should know this? Because actually you can recognize yourself that you missed out on this. And I think that is a very good way of making the older generation open to having a discussion with the next generation. And I always say that, being a gynecologist, I guess I can be more open about these things and say, when our children are attracted to each other, whether it be same sex or opposite sex at the age of 14, 15, that is normal. That is not abnormal. And so what we did as young girls, or, you can have the same conversation with men as young men, is that we suppressed that natural attraction. And so what our children want to do is explore that natural attraction. And so what we can do to facilitate them staying safe, and that's not just physically safe, but mentally safe and emotionally safe, is to be there as parents and to look at what our children's experiences with kindness. And when we get at it from a kindness point of view and from a point of view of wanting to keep them safe, and I don't mean safe in the sense of keeping your girls virgins. No, I mean to keep them safe in a physical, mental, emotional way, then we can give them the information that we would have benefited from if we had got it when we were younger.
Thank you for that. If I can come back to Debaki Ashna. Is Debaki there?
Yes.
I'm going to turn on you. So I've got a question for you, but I also want to direct you to some information that's come through the chat box, and someone saying that there is a group in Tasmania that can help support the Bhutanese community with sexual reproductive health, and there's a contact in there. So I just want you to take notice of that before the Zoom ends and it disappears. But the question that I have for you is the one that I directed to the other panelists, and what you think, you know, a practical thing that those working in the sector can do to advance the health equity of women from migrant and refugee backgrounds. Debaki? Hello? I think Debaki just left the chat. So I might go back to Dr. Kott, because there's also a question for you here that I'm hoping to get your response. And the question is, if I can just find it. It's it was a telehealth. You did answer it. So in terms of practical things that those working in the sector can do, any advice on that?
Use each and every opportunity as an opportunity to provide information that is relevant to the person you are seeing. There is no opportunity that is a wasted opportunity, whether you're seeing someone, they're pregnant, not pregnant, planning a pregnancy, whatever the situation that might be. I speak of pregnancy because I'm an obstetrician, and so, you know, my conversations tend to be around pregnancy. But at whatever stage you see a woman, use that opportunity to provide general health-related information that may be relevant to her, may be relevant to her today, may not be relevant to her today, but will be in the future. Use that opportunity. Again, I think, you know, we sometimes judge women, you know, when women come to see us and they say, oh, I've never had a cervical screening, the kind of thinking in your head is, oh gosh, here's another one who's never had a cervical screen. But actually explore that a little bit. What might be the reason for not having had cervical screening? The number of women, if you actually take the time to kindly and empathetically explore that, will tell you about some really awful experiences they may have had in the past, whether that be in the setting of having cervical screening done or actually just sexual trauma. There is so much sexual trauma out there that we are so totally unaware of. And what we're actually doing is making a judgment decision when we don't have the background information of why this woman has not had whatever it might be, cervical screening as an example. And so practically, just take the time to sit down and talk to a woman with no judgment at all, with no preconceived notions. And, you know, that is difficult again. So I think all of us should have some training in how to overcome that unconscious or implicit bias that all of us have. I have it, you have it. And so that then helps us to just have a conversation with kindness and empathy, with no judgment, and use that opportunity to provide whatever health information we can to a woman.
Stay with you. I might just stay with you, Dr. Kott, because you've been lighting up the chat box. There's another question for you that says, are there examples of initiatives which have successfully targeted women from migrant refugee backgrounds to address these health issues?
Yes, and you know, the reason I brought up that universal questioning of family violence was for this reason, that yes, we weren't targeting migrant and refugee women, but the fact that we were asking it universally meant that women of all backgrounds had the opportunity or have the opportunity to bring it up. And I think the segue to that is the fact that there are certain things that are specific to certain communities, and our understanding of those things is very limited. Now, I can speak for my own community, the Indian subcontinental community, because I understand it, I belong to it. And the dowry system, the system where women are expected to bring a certain amount of money into the marriage and are often abused in different ways if they are not able to bring that money into the marriage. And they are usually in Australia with a visa that's dependent on their spouse, with no job, with very limited English skills, unable to access any help. And so they can't leave this abusive relationship where there is constant demand for money and things like that. And so that sort of understanding of what might be specific to specific communities is not there. I mean, as health professionals, we don't have that information. But when we ask a universal question and we explain that it's not just physical violence, it's about all of this sort of threatening behavior, then women understand that and they can bring up this issue. And they can bring up the issue not only of violence from partners, but violence from other family members. Again, this is something that is, you know, universal to a migrant and refugee kind of situation where you have extended families living together, and actually the threats and violence may be coming from another family member and not from the partner. And so all of those questions may not have been targeted at refugee women or migrant women, but they actually did bring out a whole lot of things successfully and led to change in how we can help these women in those situations.
Great. Well, you know, this has been an incredibly insightful conversation, and there's still questions coming in, but unfortunately, we have come to the end of our webinar. So I'd like to end by thanking our panelists, Dr. Nisha Kott, Andrea Criado, Bonnie Corbin, and my apologies, Debaki Ashner, who unfortunately has been having some technical issues and dropped out of the Zoom. And also a very big congratulations to Dr. Tamara Kwarteng, Dr. Adele Modolo, and the team at Multicultural Centre for Women's Health on the launch of this report and paper. Thank you all for tuning in, and enjoy the rest of your afternoon.